Let us now talk about the nerves of the thoracic wall. The nerves of the thoracic wall are relatively simple once you have done the arteries and veins because they follow the same patterns. The nerves are the intercostal nerves. The intercostal nerves, as they say, they run between the ribs. These are called intercostal. So similarly, you will have 11 intercostal nerves and one subcostal nerves, that will be T1 to T11. They will have the similar pathway. They will originate between the intervertebral foramen. I will discuss. Okay, any spinal nerve. Let me get to this picture first. Any spinal nerve, let me get from this picture. Any spinal nerve, its end starts from anterior root and posterior root. The anterior root will always be motor. This anterior root will always carry the motor fibers going to the muscles. And the posterior root, this will always be sensory. As they join the anterior roots and posterior root at the point where they two meet, this point that is called simple spinal nerve or a mixed spinal nerve. This spinal nerve, it exits from the intervertebral foramen and it comes out of the vertebral canal. As it comes out of the vertebral canal, it immediately divides into two parts. The part that has to run on the lateral aspect and would go anteriorly, this is called anterior ramus, and the part that goes back through all the muscles and supply the muscles and skin of the back, that is called posterior ramus. So the posterior ramus, it's not part of intercostal nerve. So it is part, it goes back and it divides into medial and lateral branches and supply the muscles and skins of the back. So that's about that. That's all I'm going to talk about the posterior ramus. The anterior ramus, the anterior ramus is called the intercostal nerve. It as it comes forward, it runs between the two layer of muscles, the posterior intercostal and innermost, sorry, the internal intercostal and innermost intercostal. It runs between these two layers all the way in the subcostal groove in as the lowermost component, and then it runs all the way till the sternum, and till after the sternum it gives rise to the branches. So it is different from the arteries and veins in such a way that there is no anterior intercostal arteries or coming from any arteries nerves that are starting from the anterior aspect. There is no anterior intercostal nerves. There is posterior intercostal nerve or simple intercostal nerve that goes all the way to the front rather than the arteries. The nerves usually make the bigger circle. As you can see the nerves, you will see the nerves passing from the back of the intercostal vessels from the back and front of the intercostal internal thoracic artery. So the nerves are making a bigger circle, and they will have the very similar branches as you had studied in the arteries. So you will see after giving of posterior ramus, they will give the same collateral branch that will run in the lower aspect of the space, and it will give same pleural branches, same muscular branches, and there will be two major cutaneous branches. The one that is exiting from the mid axillary line to the skin, that is the lateral cutaneous branch of the intercostal nerve, giving rise to anterior and posterior branches, and all the way to the front there will be anterior cutaneous branch of intercostal nerves that will have medial and lateral branches. So these are the area skins, and this is the picture from the Snell that shows all the same things, and it is shows the muscular branches, pleural branches, lateral cutaneous branches, anterior cutaneous branches, and they have further lateral cutaneous have posterior and anterior divisions, and this is have medial and lateral divisions, and posterior ramus have medial and lateral divisions. So that's all about that. Then you are in the branches of the intercostal vessels or this segmental vessel nerves. You are talking about the white ramus and gray ramus communicatus. What are those? And now I'm slipping a little into the autonomic nervous system. This is basically the all of the nerves, they carry the sympathetic fibers with them. That's why you are able to contract the vessels and relax them with the temperature. With the sympathetic overflow, your hair becomes straightened. With the sympathetic signals, you can get sweating. So all of these signals, sympathetic fibers have to somehow get into the spinal nerve. So how do they go? Sympathetic nerves always have two components. The first nerve that is present in the CNS, that is called the preganglionic fibers. They are present in the CNS. It go and they have to synapse that is always present in the periphery or in ganglion, peripheral ganglion, and this post synaptic or post ganglionic fiber, it goes on to supply the muscle or anything that is trying to supply. So that is it shown with the light blue preganglionic and dark blue postganglionic. It starts from within the spinal cord, that is called the lateral horn, and it starts from there. It exits from the anterior root that we discussed shortly before. It enters the main spinal nerve, and after entering the main spinal nerve, it jumps into the sympathetic chain that was running uh, near the vertebral column. So this connection of the preganglionic fibers that was running uh, from spinal nerve to the sympathetic chain, this is called white ramus communicantis because they are myelinated, so they are white. Here they synapse. This cell body is the post-synaptic cell body. This is called post-synaptic, and from there the post-synaptic axon, it goes back. It does not follow the same connection. It makes its own connection that is called gray ramus communicantis, and from that it enters into the spinal nerve. And this post-synaptic fiber, it goes all the way to supply the skin, the muscles, the sweat glands, and the erector pili muscles. So all of these are the rami communicantes. So these are all the branches that you will be reading about in your books. The collateral branch, that is in the lower aspect of space, the lateral cutaneous branch, anterior cutaneous branch, muscular branch, pleural branch, and there will be rami communicantes. And then there is a special something about the first and second nerve. The first intercostal nerve, as we discussed in the skin part, the first intercostal nerve will not have any lateral cutaneous branch supplying the first intercostal space. The first intercostal space was supplied by supraclavicular nerves. Its branch, this will just move up along the neck of the first hip, and it will go up and become a part of the brachial plexus. The first intercostal nerve becomes the part of the brachial plexus, so that's its main function. It's basically the lateral cutaneous branch that goes to the brachial plexus, or the main nerve. There is still some nerve that runs on the under aspect of the first hip, but it does not supply any skin area. It supplies the somewhat the muscles and the pleura there, but it does not supply the skin. The second nerve has a special aspect also. The second nerve, its lateral cutaneous branch, it does not follow the pattern, similar pattern, but it goes to the floor of the axilla or to the medial aspect of the arm. So that is called intercostobrachial, between ribs and the brachium means arm. Intercostobrachial nerve. It runs from the floor of the axilla and go there. And this nerve is very important because this is the second nerve. T2 nerve, you get T2 dermatome right here on the upper medial aspect of the brachium, and the referred pain of the myocardial infarction. It is given into the T1 to T4, T2, and that's through the intercostobrachial nerve. The person feel pains right here on the upper medial aspect of the arm, and that you must have seen in dramas and movies. A person having a heart attack will start saying that he is having pain in the arm. So that's about the nerves. And up to the nerves number 1 to 6, they end by reaching here in near the sternum and then giving to the anterior intercostal nerves. But all the way down, the nerves, they go beyond the costal margin all the way when they reach the midline of the abdominal wall. And we have discussed in the skin part also, these segmental areas, you have to remember the dermatomes. The nerve number 4 supplies the area at the near the nipple in both in males and females. Nerve number 7, it supplies the epigastric fossa. Nerve number 10, it supplies the area near the umbilicus, and nerve number 12, it supplies an area just above the pubic bone. So these are the nerve. And innervation at the dermatome, these are important just also for the judging the spinal cord injuries, but also for the nerve blocks. For example, I don't have a picture right here. If you want to operate right here, you want to make some stitches right here. Rather than if you want to make some stitches right here, and rather than anesthetizing the person as a whole, you can pass a needle into the intercostal space and near the upper margin into the subcostal groove before mid clavicular line, so that before mid clavicular line, so that all the branches are anesthetized. So if you anesthetize all the T4, T5, T6 all the way till T10, then this whole area will be anesthetized and you can actually do surgeries here. People have done, and people still do hernia surgeries without any general anesthesia when they have blocked the intercostal nerves. So they can do that. And the point that they have to block before lateral cutaneous branch is important, because if the block is after lateral cutaneous branch, only this part will be anesthetized before, because the lateral cutaneous branch have already emerged. So blocking before lateral cutaneous branch, before mid axillary, and now again surface landmark comes into importance, was important. So that's about that. About the intercostal nerve, we have discussed dermatomes, supraclavicular nerves, and all. We have discussed the referred pain in coronary heart disease and the importance of intercostal brachial nerve. And the last thing I want to talk about nerves is infectious disease that is called herpes zoster virus, shingles, chickenpox, the virus that causes chickenpox, herpes zoster virus. Sometimes it becomes when person gets infected, the virus becomes dormant. After healing, the virus become dormant and get lodged here in the nerves, in the ganglions here. Sometimes it gets reactivated when a person is immunocompromised, and they spread along the nerve and apply the skin part. So you can see the person is having the lesions in the dermatome pattern. So the person will have the blisters, the lesions in a particular dermatome, the dermatome that is infected, and that's actually a very painful condition, herpes or shingles, and that can affect the dermatomes of any nerves. This particular example is showing the shingles or in the intercostal dermatomes. They may develop in the other dermatomes, in the even the face dermatomes and in the abdominal region also. But the characteristic pattern, the characteristic dermatome pattern following, that gives away that it is this particular disease. So that's about all about the nerves of the intercostal spaces, intercostal nerves. If you have any questions, if you have any suggestions or feedback, please do mention. And don't thank me yet. I'm still going to go ahead for the diaphragm, because if I don't do it today, it won't get done. And for the people who are on the live lecture, you are very okay to go on a leave or a break, because then I will make these recordings available for you. But I will continue my lecture for the diaphragm also. I'm sorry for keeping you up for this much, but still. Okay, you have asked about what are white ramus and gray ramus communicantes. So I just talked about this nerves, this preganglionic fibers and postganglionic fibers. These are always, they will synapse and they will go through before entering the uh, breaching area. So this is in the blue, light blue, this is preganglionic fiber, and in dark blue, that is called postganglionic fiber. So the preganglionic fiber, as it exits the spinal cord, it exits through the ventral route, then goes to the spinal nerve, and this connection between the spinal nerve and the sympathetic chain that carries the preganglionic fiber, this is white ramus communicantis. And that connection with bring back the postganglionic fibers back to the spinal nerve, that does not go back from the same connection. This connection is called gray ramus communicantis. This is white because it is myelinated. This is gray because it is unmyelinated. So this is white and gray rami communicantis. The white will be lateral and gray will be medial. Okay, so that's all about that.